Top Med Talk.
Welcome to Top Med Talk, the broadcasting arm of EBPOM, evidence-based perioperative medicine. Stand by for a healthy conversation. But first, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. It is organised by iPOETTS, the International Preoperative Testing and Training Society. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org. And remember, this is an International Perioperative Testing and Training Society accredited event. So when you attend, you can get your iPOETTS accreditation showing that you are a practitioner who has reached a high standardized level of competence in performing and interpreting cardiopulmonary exercise testing for patients preparing for major surgery. Check out ebpom.org now.
Hello and welcome to Top Med Talk at EBPOM 2026, live from the British Library here in London. We are currently in the mid-morning break. I'm Joff Lacey, and I'm joined by Imogen Fecher-Jones.
Good morning, Joff. Great to be here.
We've just finished a very enjoyable and very important session here at EBPOM, which is the oral presentation of abstract finalists, and it was a great session, wasn't it?
Yeah, it was fantastic. We have 6 really diverse projects from across the world. So yeah, really interesting session.
And we're lucky enough to have all 6 finalists here in the Top Med Talk booth. And we're going to rattle through the highlights of the work they've done. So we're going to start with Nora Cruz Rodriguez, done a lot of work at UCLH. Nora, could you just take us through your abstract and your findings?
Yeah, this was a retrospective analysis. At UCLH, we have a prehabilitation program, and this program has been running since 2022. And we collect a lot of information from the program. So what we did, or what I showed just in the presentation, was the association between this remote prehabilitation program and postoperative length of stay and hospital length of stays. The program started 2022 after COVID, and a lot of the healthcare system changed. So we start developing or providing more remote healthcare. So this rehabilitation program runs remotely. And what we found is that after patients engaged in these remote exercise sessions, their hospital length of stay was decreased by 18% high-dependency unit and 20% as overall hospital length of stay. So it looks like remote rehabilitation has an impact in general complications, because if the complications are lower, the length of stay in hospital is also lower.
Now, how were the remote sessions delivered? What was the format?
So this is complex because obviously we want to engage all the patients as possible, but there are patients who already are participating in an exercise program. And also we have patients who require a little bit more of push to exercise, or patients who are very well doing by themselves. So we have 3 groups. One group where patients participate in the 2 weekly group exercise session. It's like a team session where they join to other people and they're exercising with the physiotherapist. Patients who said, I don't want to participate in the group exercise session, but I have something like I cycle or I walk or I run or whatever. So the physiotherapist engaged them and they set goals. So they said like, okay, you are used to cycle. How much do you cycle? Let's set goals to progress through the exercise journey. And we have other patients who require a little bit more support. So these patients join to one-to-one session. Everything is remotely. We one-to-one sessions with the physiotherapist where they closely monitor that they are properly doing the exercise and they are progressing within the program.
And talk to us a bit about your control group. Who are you comparing this group with?
Well, this was retrospective. So all the patients and we compare oesophagectomies and radical cystectomies. At UCLH, all the patients who go for oesophagectomies and radical cystectomies recover in the high-dependency unit known as PACO. So all the data collected was from PACO. And what we did was just like same time frame, 2022, 2025, similar populations. So we try to match patients, but just comparing with the patients who didn't have prehabilitation. And we're very similar. So actually the prehabilitation patients were a little bit older but both populations were around the 60s. Most of the both groups were mainly men, 70%, and most of them, 80% of the patients, were classified as an ASA 3 or 4, but very similar populations.
And have you now changed your routine preoperative management for these patients? Is everyone now getting the remote prehabilitation?
Well, I think that's the problem, because obviously we have a limited number of physiotherapists. So even if it's remotely, it's very difficult to match put all the patients to have prehabilitation remotely. And the other thing is we don't have a way to monitor them remotely. So we know that they are exercising, but we have no way to monitor what they are doing at home. So we are trying. Obviously, we want to have as much patients as possible. And with these studies, we can say, well, we found the difference for this population. Just let's extend this to, it works for cystectomies, it works for oesophagectomies. Let's do it for other populations like lower GI, gynae. So obviously, we want to try to extend this as much as money allows.
Brilliant. Thanks very much for that. And now moving on to Alexios Dosis from Leeds. Alexios, welcome. Would you mind taking us through your work?
Hi, it's great to be here. Well, my background is a little bit different. I'm a surgeon in training. I'm high surgeon training.
You're welcome, sir.
So it's great to be on it. It's an anesthetic conference, but I think my work fits nicely here. Essentially, my work follows on from one of my previous colleagues who looked into wearable devices in the post-operative setting and wondering about complications. And so with obviously the rise of COVID and everything else, we thought that it would be nice to explore the wearable devices in a different setting. And that would be our interest, was to see if we could assess the patient before getting even to the surgery date. And initial work and pilot work was done, and we had a good system in place, and we thought that we set up a feasibility study. We got funding. Big thank you to our funders from the Leeds Hospitals Charity and Bowel Cancer Research UK. We did a feasibility study, and essentially patients were fitted with a wearable device that is applied on the patient's chest. And the benefit of that device is essentially that it can capture continuous physiological data, and that is ECG. It has 2 lead ECG sensors and also activity data with a triaxial accelerometer. And obviously the patient is monitored on a continuous manner at home in their own environment, doing things that they like and outside of the stress of a hospital setting. And this is usually for 72 hours, was the intended target initially, but some patients proceeded to keep the sensor even longer. So we've had patients being 80-year-old wearing the device for 120 hours in the study. This project was around feasibility, so we just wanted to see initially, is this something that is doable in an out-of-hospital setting? Because obviously these patients are going through, the majority were going through a malignant process, so it was obviously very stressful for them. Think the diagnosis of cancer, as you probably understand, is quite daunting for patients. But we had very good uptake. Recruitment was around 60% uptake, and it was consistently high throughout the study. That was very encouraging. In this particular setting, the patients were not getting something back from the research that was proposed to them. It was mainly contributing to us. The results were very encouraging. Most patients tolerated the device very well. There were obviously some hiccups here and there, disconnection problems and some adhesion issues. Adhesion problems were not very common, mainly were in the warmer parts of the year, like summer months. The disconnection problems were somewhat hindering in some occasions, but essentially one of the findings from the study was that a support system should be in place for these patients so that they can contact research teams, or in particular, if this comes to a fruition in the future, hospital teams, so that they can get some troubleshooting. But this is something that is doable. And when we also collaborated with the School of Computer Science in the University of Leeds, had great colleagues there. So we didn't use proprietary algorithms like most studies have done already. We used the actual raw data that we had for our patients. And my colleagues in the computer science team have managed to quite a few clever featuring, essentially, develop algorithms and extract features that are very useful for prediction modeling. So we looked into fitness estimations. We looked into different wearable features with a range. So obviously we had the ECG data. You could get resting heart rate, maximum heart rate, sedentary heart rate, all these things. You could get the activity for the patients, how many steps they've done a day, how active they have been throughout these 3 days, what is the total distance they've done. Also, we looked into what's called in the literature lately contextualizing heart rate, which is essentially trying to marry the two together, like when the patient is in certain intervals, when the patient is moving faster, which would indicate a moderate or vigorous physical activity, what is the heart rate response? So essentially, it's like an indirect measurement of them being stressed in a way. And that, I think that's a very helpful feature in wearables, because although obviously the patient is not fully stressed as in the cardiopulmonary exercise test, it's something that can provide insights into how they are behaving in a stress situation.
Brilliant stuff. So it can be very useful in risk prediction for major surgical patients in the future. Thanks very much. Next, we have Ned Douglas from Melbourne. Welcome from that far away. Thank you for coming. Please tell us about the abstract work you've done. This is a pilot trial for the FAME study.
No, thanks. In this study, we looked at patients who were hypotensive in PACU after having non-cardiac surgery, and we randomized them in a feasibility pilot to one of a placebo 3 times a day, 10 milligrams of Midodrine 3 times a day, or 18 milligrams of Atomoxetine followed by 2 placebo tablets. We're really interested in the feasibility aspects of this trial because we're randomizing in PACU. We need to use consent to continue, which is allowed in Australia, as a way of finding patients who are most likely to benefit from an intervention like this. And we just weren't sure how many patients we'd be able to find, recruit, and get to be in our trial. So our recruitment rate is the primary outcome. And then we had a bunch of other feasibility things that we were interested in, and always some clinical data, though we're a bit nervous about interpreting clinical findings from feasibility trials. Yep.
And what were your findings with both the feasibility, but we won't take the clinical findings as read, but what did you find with those small number of patients?
The feasibility things were reassuring. We think we can run the trial. We will need a few more centres because we recruited 2.8 patients per week compared to the 4 that we wanted. But most patients got the drugs they were allocated, and the blinding worked, the stats worked kind of as we expected them to. And the patients were happy to be in the trial. That was probably the most important finding. So only about 3% withdrew. In terms of the clinical findings, which everyone's excited about but really needs confirmation, the real surprise was that Midodrine appeared to increase the rate of hypotension. It might have doubled it. Whereas Atomoxetine, which is a selective norepinephrine reuptake inhibitor that was invented to treat ADHD, but also is used to treat autonomic dysfunction in patients where other therapies have failed, that appeared to be associated with only a modest increase in blood pressure, but significantly less ICU utilisation and more days alive and at home at 30 and 90 days. And I think if I was tempted to overinterpret, what I might say is that propping the blood pressure up just above the thresholds we use for referral to ICU or a medical emergency team call allowed the patients to be more well and do the ERAS bundles of care, get up, get moving, as opposed to being seen as hypotensive, risky, can't move on with their care. So we think that's a really exciting, interesting thing to explore in a definitive trial that we hope to do soon.
Just going back to your recruitment rates, that's obviously a challenge within feasibility that you need to know, you can be assured with. What was it? Was it down to your eligibility criteria that you got less than you were expecting?
It's a great question. I think our eligibility criteria was too restrictive. We did base it off the product information because that's what the ethics committee would let us do. But there's some things in there, particularly the exclusion for dialysis and renal failure, where that is actually an indication, an listed indication for Midodrine. So losing that would be helpful. There's a precaution in there about using Atomoxetine with patients on SSRI drugs and other inhibitors of the liver enzymes. And I think that risk is probably overstated, and we could probably expand the recruitment pool. But the reality is there was lots of things that ended up getting in the way from the whole grab bag of reasons that and to be frank, there's a fair bit of variability in how many patients are hypotensive in PACU as well that goes with surgical case mix. We didn't recruit anyone on a school holiday week, which makes me suspicious the surgeons were doing the easy operations on school holidays, but I'm not sure if I'm allowed to say that.
You absolutely can, yeah. Well, that's great. It's a very exciting study. We look forward to the trial itself, because obviously that could be very helpful in utilisation of critical care in the post-operative setting. So great work. Thanks very much for that. And now moving on to Tom Scodellaro. Welcome, Tom. Could you now tell us about your abstract findings?
Sure. So we undertook a retrospective audit of CPET results in our patient population, particularly looking at patients over the age of 80 to try to better understand what is a normal result in that older patient population, which we know is becoming more common, as well as analysing that data to identify, the proportion of patients that are high risk and comparing our results to many of the algorithms that exist to predict peak VO2 in these patients.
So a concern that we are misinterpreting this particularly high-risk group, is that what you were looking into?
Correct. So misinterpreting is perhaps not quite the right word, but perhaps using kind of a population-based model to identify what is a normal result in this patient group to better inform our clinical decision-making, as well as shared decision-making. Those that are familiar with CPET know there are metabolic thresholds or cutoffs that categorize patients as high risk or less high risk. And I think regardless of whether you fall into those gaps groups because of your age or because of comorbidities, I don't think we should dismiss those things. But being able to compare patients to their peers is perhaps a useful tool for clinical assessment.
And you had nearly 5,000 in your sample, so how many of those were over 80?
Yeah, we've looked at data over the past 13 years, which is about 4,800 patients. 16.5% of those were aged 80 years and older. And when we excluded tests that were inadequate or had missing data, we had about 677 patients across a range of surgical specialties. Patients having upper GI surgery, liver surgery, transplant surgery, colorectal surgery, for example.
And what did you find?
Interestingly, on that population note, we found that we tested far more men than women. It's about a 60 to 40% split. And I think that's something we need to look into about why exactly that's happening. And we found that a large group of these patients do fall into the high-risk group, and that's not surprising. So about 35% of our population you can categorize as having an elevated perioperative risk based on an anaerobic threshold less than 10 and a peak VO2 less than 15 milliliters per kilogram per minute. We saw there was a lot of variation in CPET results in terms of anaerobic threshold and peak VO2. And I would hypothesize that's due to the complexity of these patients in terms of their frailty, medical comorbidities, and their pathology. And the other thing we found is when we compared paired samples of these patients' peak VO2 with predictive algorithms, not surprisingly, the predictive algorithms for peak VO2 were very poor or correlated very poorly with our results. There was only one algorithm, the Jones 2 algorithm, that was not statistically significantly different from our population results.
So what's your next steps then with this work?
There's a few internal things we need to do. One I mentioned to try and understand better why we're testing fewer women. And I think we need to be careful that we're not seeing a split in terms of under treatment or under investigation on a gender basis. One of the next steps is develop a tool so that we can use this data to generate a normal distribution and using a patient's age and gender and their results, be able to generate kind of a percentile figure that can help with our work. That's perhaps the main things for now. The next steps, I think we just have to be careful with what we do with this, that we're not just generating kind of an extra piece of data that's going to muddy the water, but rather we're very careful with what we do and perhaps applying this to patients who are already high risk in the way that helps us with our shared decision making.
Because I guess these are patients as well that have been referred to CPET for a reason. So by, characteristics, they were higher risk. So I guess we have to be slightly cautious when looking at the normal in that particular population, don't we?
I absolutely agree. The normal in this context is how we've generated a new normal distribution for this patient group. And as it's shown that, 35% do fall into high perioperative risk group. So I think we absolutely need to be careful with how we interpret that.
Thanks very much, Tom.
Thank you.
And now we have Gerry O'Callaghan, who has also travelled from Australia, from Adelaide. Gerry, thanks again for coming all this way. Could you tell us about the work that you just presented?
Sure. So surgeons have a lot of decisions to make, really. They've got to decide, who to operate on, when to do it, what operation to do, who should do it. And in modern healthcare systems where all of this information in terms of decision making and outcomes is in the electronic medical record, our work was really about how do we get data from that, turn it into information that's really helpful for surgeons and perioperative physicians and other members of the team to make better decisions. So we looked at readmissions and representations back to hospital after surgery in the first 30 days and really got into the detail of, who, when, where, how. Because, of course, so almost 20% of patients represent at some point. The vast majority of them are not admitted. In previous work, surgeons have determined that almost half of those representations and readmissions are avoidable. So we really wanted to get our electronic medical record to provide that information back to the clinical teams making those decisions. About 20% of people who we present go to a different hospital than where they had the surgery. And then in addition to that, there are kind of different rates and volumes, and people spend a lot of time in the ED. So then we looked at that and we found that people who come back to hospital represent and not readmitted are spending, maybe 7 or 8 hours in the ED. So that looked at something like 800 hours of ED occupancy every week in our system for people representing after surgery, and the vast majority of those were not admitted. So that was really the essence of the work. And obviously we broke it down by service, type of surgery, site of presentation, and that was really the nature of the work. Because the vast majority of people who come back following surgery are coming back with non-kind of surgical things. So the surgeons don't really hear about it unless we create those intentionally designed systems.
This was a huge study, wasn't it? I mean, how many participants did you have, or how many patients were you tracking?
We looked at 50,000, almost 50,000 surgical separations over 2 years.
And I think somebody asked about, when you presented about the 30-day, is 30-day the right marker we should be looking at? And you had some good responses to that.
Yeah, well, I'm a recovering chief medical officer, so I understand that a lot of the information that is collected in systems is done so for the purposes of funding, planning, and resource allocation. So 30 days is very commonly captured as a quality indicator. And all of the work that we're doing across various different domains, and sort of perioperative medicine is one of them, we really don't want clinicians and clinical teams to collect more information or to make their life more difficult. We're saying all of this information is in the electronic medical record. We really should be able to make some sense of it for people so that, they're getting the benefit of entering that information. And of course, for consumers, that they're the most important group of people.
Feeding back what you found to the clinicians in your hospital, what's been the kind of reception?
Well, I think, when you feed back information to clinicians, they always want more information, more data. So, we have had some very good feedback. We've got a clinical reference group that we work with on each particular project that we do. And we come back and we say, well, what kind of, does this make sense to you? So I guess the next thing will be to plan an intervention, because there actually is a lot of evidence already. It needs to be translated into practice. And so we're working with a couple of our clinical teams with the higher readmission rates, see whether or not we can do an intervention study and bring it down. I mean, it's already pretty good by international standards. I mean, it's 10% for emergency surgery and 6% for elective. It's pretty good. But actually the prize in all of this, if you think about it, is how can surgeons do more elective surgery? Otherwise, what will happen is if you create capacity in the health system, they'll just have to do more elective surgery, or people will just have longer lengths of stay. So we really need to create, quite defined parts of the system where surgeons can do more elective surgery, more planned interventions, because they're usually more complicated and often they're for cancer and for those other kind of really important issues. And at the moment, there's far too much kind of cancelled surgery on the day. So I think that's really the kind of direction that we'd like to go in.
Fabulous. Thanks very much for that. And then finally, Sandy Jackson from Southampton. Can you tell us about your abstract, please?
Hi, yeah, it's great to be here. I was presenting some data that we've developed with colleagues internationally, actually looking at the cost of arterial line insertions, specifically radial arterial line insertions. And what I was presenting today was the UK cost model. We've got data from the US, we've got colleagues working on Australian models, and always interested in wider places, but we were specifically looking at that UK data today.
And tell us how you put together the numbers and what you found for the cost of a arterial line insertion.
Yeah, absolutely. So we kind of look across 6 different domains. So one of those is the cost of time in operating theatre. So we looked at how much a UK operating theatre costs, and we used some data from Tim Briggs, who many of your listeners may know from the GERF programme here in the UK. And then we looked at how long it takes on average to insert an arterial line, and we collected that data both through a survey of clinicians and direct observation of clinicians inserting arterial lines. And then we look at the supply costs. How much does an art line cost, be that Seldinger art line or just a straightforward cannula art line? How much the bag of fluid cost, the giving set, the transducer, all those bits and pieces. We then look at the costs of removal. So obviously someone's got to take the thing out and apply pressure. So we costed that at a band 5 nurse, spending about 10 minutes in total getting the thing out. We looked at the waste disposal cost. So again, you produce waste, you've got to dispose of it. That costs money. We looked at the complications. Now, the complications with arterial lines are relatively infrequent, but we account for those. We say how frequently they occur based on the literature, what the cost of those complications are, again, based on the literature. That was kind of an international piece of work. that we then scale according to OECD estimates of sort of relative healthcare costs to what we have here in the UK. And then we did consider setup time. So, how long it takes someone to get the kit ready for you to put the art line in. And I did talk a little bit about the environmental cost, but we haven't quite finalised our methodology there. So I don't want to put it in as a headline figure, but we did look at the environmental consequences.
So what's the next for this, Sandy? Because clearly we're not going to stop putting in art lines. So is it about putting them in quicker?
Yeah, well, so I mean, that's the thing is that it showed time is what costs money, right? So 90% of the cost was that operating theatre time. So yeah, sure. I mean, if you can get quicker, great. I think it's more just about saying that if you're looking at alternatives to arterial lines, because there are increasing options available that provide you high fidelity continuous monitoring without needing to put a physical arterial line into a patient, when you're looking at those alternatives, don't just say, well, an arterial line costs 30 quid and that costs more than 30 quid. Look at the whole picture. Say, how long does it take to put this in? How long does it take to put that in? What's the quality of the monitoring like? What's the whole package? What's the patient experience? So I think it's just about raising that point, that it's not just about the cost of, the consumables, which I think is sometimes when you're writing a business case, people see.
And that we've got to consider the cost often in the NHS, not always considered, but we do need to think of that when we're making our decisions as to what monitoring we're wanting to use.
I think I said in the abstract, I don't think this should necessarily change people's threshold for when they put an art line in, but I just think it's worth being aware that nothing comes for free. And if you're getting benefit from it, by all means do it. But equally, if there's an alternative that gives you the same outcomes for less money, that's better for a society. And whether that is the same outcome is you don't actually need the monitoring, or you do need the monitoring, but there's a cheaper alternative in the round.
Excellent. Thanks very much, Sandy. And thank you to all our contributors and also to our sponsors, BD Advanced Patient Monitoring and GE Healthcare. Please find all the TopMed Talk podcasts on your platform of choice or visit our website at topmedtalk.com. Like and subscribe. And most importantly, remember that abstracts for EBPOM Ireland are open. So please get writing and submitting. But from me and Imogen, that is all for now. Thanks very much.
TopMed Talk.
And remember, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org.